Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Glucocorticoids are both a rheumatologist's best friend and worst enemy. They're very effective at treating acute disease flares because they work quickly to control the inflammation no matter where it's located in the body. Glucocorticoids also remain a part of the backbone in the long-term management of many chronic diseases that we care for, including lupus nephritis, systemic vasculitis, inflammatory myopathies, polymyalgia rheumatica, and many others. The problem is that glucocorticoids have a lot of long-term side effects: decreasing bone mineral density, hyperglycemia, weight gain, skin fragility, among many others. This is why recent clinical trials have attempted to find the lowest effective dose and duration of glucocorticoids for many rheumatic diseases. Osteoporosis is one of those nasty side effects that, if left untreated, can actually lead to significant morbidity and mortality among people with rheumatic disease. Within the first 3 to 6 months of glucocorticoid use, patients already can experience significant rapid bone loss. To mitigate some of these side effects, the American College of Rheumatology has developed guidelines to prevent and treat glucocorticoid-induced osteoporosis, and these guidelines were most recently updated in 2022. To help us unpack these new guidelines and understand their implications, we've invited the lead author of the guidelines, Dr. Beth Humphrey. Together, we'll discuss what the guidelines entail, the importance of early fracture risk assessment, the role of pharmacologic treatments, and the nuanced care required for special patient populations, such as children and young adults. Dr. Humphrey is professor of medicine, section chief of rheumatology, and the associate dean for research for the College of Medicine at the University of Oklahoma Health Sciences Center and the Oklahoma City VA. She obtained her MD, PhD at Baylor College of Medicine and then completed internal medicine and rheumatology training at the University of California, San Francisco. Enjoy the show. Beth, welcome to the show.
Thank you, John. I'm really excited to be here. Glucocorticoid-induced osteoporosis is a big problem, and we really need to champion better care.
I love it. Tell me about what it is and why should people with rheumatic diseases be concerned about GIOP?
Well, even despite all the good drugs we have now for rheumatoid arthritis and lupus and other diseases, we still have a lot of patients that are on some dose of daily prednisone, mostly prednisone. And we know from good clinical studies and basic science studies that steroids really have a strong impact on bone and cause bone fragility. The effects of the steroids can happen as early as 3 months after starting steroids. And surprisingly, even doses as low as 2.5 milligrams of prednisone can cause spinal fractures or vertebral fractures. These compression fractures can be very painful for patients and lead to significant disability.
That's right. I hear that, sustaining a hip fracture, the likelihood of death within a year is quite significant.
Yes, that's right. So doses of 5 milligrams and higher of prednisone for months greater than 3 months can actually significantly impact the hip as well and cause hip fracture. And so, roughly 50% of patients that have a hip fracture will not be able to walk independently after their fracture. They may have to go into assisted living. And 25% of men that suffer a hip fracture will die within a year. So really a scary number when you think about cancer. Most patients don't, 25% of cancer patients don't die within a year of diagnosis. So this is a really big problem that we want to avoid.
Huge, and it's often overlooked. Sometimes we get so involved in the management of the rheumatic disease, whether it's treating the lupus or the vasculitis, that we sometimes forget about some of the side effects of our own medications.
Right. And we often inherit patients, from primary care providers or from other rheumatologists even that may have been on 5 or 10 or even 20 milligrams of prednisone for years and, without any intervention. And these patients are at very, very high risk.
I always remember one of my previous mentors, wanting always to push down on the prednisone dose and asking patients, what happens if you lower it? And for some patients, they've never even tried, lowering the doses. And he was always, pushing. It's like, what happens if you lower it? Right? It's like, do you really need the 5 milligrams? Can you get away with 4 or 3 or even less?
Yes, definitely. And since I've worked on these guidelines, the last 2 sets of guidelines, or the current guidelines and the 2017 guidelines, I've been a big champion for that 1 milligram a day, try to taper down to the lowest effective dose. And if you can get off, all the better.
Fantastic. So, the American College of Rheumatology has been involved in developing guidelines for preventing glucocorticoid-induced osteoporosis for years. Why did these guidelines need to be updated?
Yeah, so the first guidelines that were made, I believe, were in 2010, and then the next guidelines were 2017. And so the ACR has update guidelines every 5 years or so. And actually, this will be the last 5-year update. Moving forward, we're going to move to a living guideline model where they'll be updated yearly or every 2 years. But this particular guideline needed to be updated because we had 2 new FDA approved osteoporosis medications, romosozumab and abaloparatide. And we had new data on requiring sequential therapy after stopping denosumab and after stopping romosozumab, and even the thyroid hormone medications like teriparatide and abaloparatide. So we really needed to be aggressive at alerting our providers that there are significant changes that need to be made.
Fantastic. So let's delve into the guidelines a little bit and start talking about what kind of patient should be screened for osteoporosis and how should we screen for them?
Yeah, so this is actually, interesting enough, a difficult question to answer by evidence. But in general, any patient over the age of 5 that is on more than 2.5 milligrams of prednisone should have at least a clinical assessment for steroid-induced osteoporosis. And then depending on what their age is, we make further recommendations about whether or not they need DEXA scanning or vertebral spine x-rays looking for vertebral fractures. So in general, if a patient is, we'll just say over 18, taking more than 2.5 milligrams of prednisone a day for more than 3 months, you anticipate it will be more than 3 months, they should be screened clinically. And that includes looking for falls, looking for whether or not they drink excessive alcohol, more than 2 alcohol drinks a day, whether or not they smoke, are postmenopausal, or have hypogonadism, either by age or because of chemotherapies, perhaps, if they've had prior fractures, if they're low body weight, or had a significant weight loss. We also ask questions that fall into the FRAX, which we can talk about later, which includes parental history of hip fracture. And then we want to know about comorbid conditions like rheumatoid arthritis, chronic liver disease, hyperparathyroidism, inflammatory bowel disease, and many others.
Got it. So it makes sense for anybody that, is whether a child or an adult who's going to be on steroids 2.5 or higher for long periods of time, it makes sense to sort of look at their clinical risk factors and try to assess the risk, whether they're, very high, medium, or low risk for future fracture. I think one of the challenges that I see from these guidelines is that, anticipating that your patient will be on steroids for 3 months or longer, because we always, at least I do, I start a patient with lupus or rheumatoid arthritis with just a little bit of steroids to get them through this flare, and it's maybe 5 milligrams, or maybe you start at 10 and you decrease to 5, and you think that it's only going to be for a few weeks, maybe a month, and certainly by 2 months they're going to be off. And then it's 6 months later and they're still on prednisone, and you're like, oh shoot, right? I should have assessed their bone density a long time ago. And it's challenging making those anticipations of steroid duration.
Yes, I would agree, especially when you're we often will use some steroids early on when we're starting other disease modifying anti-rheumatic drugs. And with the anticipation, we'll get them off in less than 3 months. But there are some diseases, glomerulonephritis, maybe, pericarditis, really life-threatening complications of some of our diseases, even giant cell arteritis, even with the rapid taper, they're going to be on steroids, high-dose steroids for at least a month or two as you try to taper down, or 3 months. So for those patients, really, trying to make sure you're not missing them. And then, yes, unfortunately, I think we do all have some that we anticipated would come off, and they just are not responding to the other DMARDs or the biologics, and they are staying on steroids. It's never too late to screen. So go ahead and screen them at that point, even if you missed the as soon as possible screen. We still recommend screening as soon as you realize they're staying on steroids.
I think another point that the guidelines make is that osteoporosis or bone loss happens actually fairly quickly after starting steroids. 3 months, if they've been on it for 3 months or even 6 months and you haven't intervened, like, they will have had some bone loss.
That's very true. Most of the bone loss can occur in that first 3 to 6 months, which is why we're trying to advocate for early. But we do realize there's always patients that don't, and you've seen it, and I've seen it, that there's been patients that have been on steroids for a long time and they still have normal BMDs and bone mineral densities. And you're like, how is this possible? But, we still want to catch people as early as possible.
Yeah. So let's discuss, an adult 40 years of age or older that, maybe they have, polymyalgia rheumatica, and they're going to be on, they're going to be on steroids for quite a while. So in addition to the clinical risk factors and discussing, sort of comorbid conditions, what are the recommendations for screening them for osteoporosis risk?
So for any patient over the age of 40, we recommend doing the FRAX assessment with the glucocorticoid correction. And that would mean that for the FRAX, this is something that was developed by the University of Sheffield, and it really looks at the age and the height and the weight of the patient, and then previous fractures, parental hip fracture, current smoking, steroids, up to 7.5 milligrams, rheumatoid arthritis, alcohol. And then if you have a bone mineral density, you can include it, but you can do the FRAX without the bone mineral densities. So practically most of us, I think, start with the FRAX without the BMD, because we don't usually have the DEXA in hand at that same time. And then we'll refer the patient for a DEXA. And with the DEXA, you can get the bone mineral density at the hip or the spine. And I believe the FRAX asks for the hip bone mineral density. And you can get a vertebral fracture assessment. They can look for silent compression fractures that might already be there, or they may have even been symptomatic compression fractures. And so we recommend getting that done as soon as possible, that the patient's going to be on long-term steroids, and certainly within 6 months, if you inherit the patient, then, basically when they come to you on steroids.
Yeah. And, I don't know if you have experienced this challenge, but oftentimes, that patient with polymyalgia rheumatica, I send for DEXA. Sometimes it takes a while to get that study scheduled, and, yet more delays that may happen that may prompt you to delay initiating treatment. It sounds very reasonable to do the FRAX, to get a DEXA, the vertebral fracture assessment as soon as possible. What's the difference for people under the age of 40, say, adults from 18 to 40?
That's a great question. And I think something that not everybody's aware of is that the FRAX is only validated for ages 40 and above. So that's where the cutoff is in our guidelines, is that people under 40 have such a low fracture risk at baseline that it's very hard to look at their BMDs and with or without steroids and predict fracture. So in those patients, you cannot use the FRAX. You have to basically go on to a DEXA. And so for anybody under the age of 40, 18 to 40, we do recommend getting a DEXA as soon as practical when you're starting steroids for more than 3 months.
Fantastic. And can you discuss how we should screen children, so those under the age of 18, for osteoporosis?
This is a really interesting dilemma, John. We had some pediatric clinicians on our guidelines, and I was really surprised to find out that even in the pediatric world, there is great controversy over what is pediatric osteoporosis. And so some organizations say you have to have multiple fractures, either multiple vertebral fractures, 3 or more long bone fractures. And it can kind of be all over the place. Some guidelines, other organization guidelines say don't even get a DEXA or a spine x-ray unless the child has back pain. And so really, we have no great evidence to tell us what is a very strong recommendation. So our guideline committee basically decided for children under the age of 18, if they have back pain or they've had clinically significant fracture or fractures, that we recommend starting off with a BMD. But if they haven't had those things, that you don't need to get a BMD or a DEXA.
It makes sense. As a pediatric rheumatologist, these patients are challenging. Often, we sometimes give them a lot of steroids for a long time. And, so I treat both children and adults. I'm always thinking, wow, in an adult, I would put this patient on alendronate. But I guess part of the challenge is that treatments for pediatric, osteoporosis aren't as well supported as in adults, and there's also some concern about potential side effects.
Correct. Yeah, if you're going to put a child on a bisphosphonate for 10 years, and then they still go on to adulthood, you're looking at long treatment periods. I think the most critical thing or most exciting thing to think about for children and even young adults, they have a great capacity to rebuild bone when the steroids are stopped. The older we get, the less ability we have to rebuild our bones. But for young adults, people under 30, and for children, once the steroids are stopped, they often can rebuild a substantial amount of their bone. And so that should also give us some reason to realize we don't necessarily have to overtreat those young adults and children.
Fantastic. That's very good to hear. All right. So we have my patient with PMR. We do the bone mineral density scan and the FRAX score. And then what we get, we incorporate that data in a very complex risk assessment, right? It's not easy.
Getting more complex every guideline.
Oh my goodness, right? There's a lot of levels of risk. I certainly have to have, it's great that you, within the guidelines, you included these illustrations about sort of the various different types of risks and how they are, who fits in those risks. So how did you think about creating all these risk assessment categories, from very low risk adults to very high risk adults and everything in between?
Correct. So the previous guidelines had low, moderate, and high risk. And with this particular guideline, we added the very high risk adult group and even young adult group to be better in line with what other endocrine and osteoporosis organizations were publishing for their guidelines. And so let's start with that group, because I think that's the scary group. So the very high risk adults, so this is anyone over the age of 18, is somebody who has had a prior osteoporotic fracture or multiple fractures, or a BMD if it's an adult over 40 with a very low T-score, lower than minus 3.5. Or if they've had FRAX, they have a 10-year risk of major osteoporotic fracture of greater than or equal to 30%. And so remember, the cutoff we usually use for FRAX to treat or not treat is over 20% for a major osteoporotic fracture. So these people have a 30%. 3 in 10 will fracture in 10 years if we don't treat, right? And then hip fracture, the normal cutoff we use to treat is 3%. And for this very high risk group, it's 4.5% or higher. So that's the majority of who is in the very high risk group. This also includes younger adults who have had prior fractures, or any adult that is on steroids more than 30 milligrams a day for more than 30 days, or if you add up all their steroids they've gotten in the year is more than 5 grams. And keep in mind, patients like that have vasculitis or glomerulonephritis may have gotten pulse steroids with 500 milligrams or 1,000 milligrams for several days in a row, and then they're on some dose of steroids after that. So patients can actually get to 5 grams fairly easily when we're looking at our life-threatening autoimmune diseases.
Yeah, I mean, previously I thought that, maybe only a minority of patients would fall under the very high risk category. But in thinking about many of our patients, many of them have had, vertebral compression fractures and would automatically qualify as being very high risk.
In the past, we considered them high risk, but in this category, we've now separated them out because we want to promote using an anabolic agent in that group of patients.
Yeah. So tell me a little bit more about that. So I think that's absolutely right. So you wanted purposely to classify this very, very high risk patient group because you think that they deserve a different type of treatment that we would provide somebody with maybe moderate risk.
Correct.
Tell me a little bit more about how you think about, what type of treatment these patients deserve.
So the very high risk group is very high. It has a very high risk of fracturing. And so we do have data that shows that the anabolic agents, such as teriparatide or abaloparatide, improve the bone mineral density faster than bisphosphonates, and also reduced glucocorticoid-induced vertebral fractures better than bisphosphonates. So we have, in this guideline, we have made the recommendation to start for this very high-risk group on an anabolic agent, which currently is teriparatide or abaloparatide, over a bisphosphonate or denosumab. But we also recommend that you could use denosumab in this group. Although it's anti-resorptive, it does have an anabolic component to it. And or you could use IV bisphosphonates or oral bisphosphonates. There's still a very strong recommendation to use an oral bisphosphonate over no therapy. So if your insurance won't let you start an anabolic agent in this group, we would still recommend an oral bisphosphonate over no treatment for this group. Let's talk about the moderate risk. So these people have either FRAX scores that are between 10 to 20% for fracture of the major osteoporotic fracture, or their hip is greater than 1 but less than 3. There's some BMD numbers there. And so there it's recommended that you could start with either an oral bisphosphonate, an IV bisphosphonate, denosumab, or any of the PTH analogs. And so this group doesn't need as rapid bone building as the very high risk group does.
Got it. So this is a patient group, just to clarify, that if you weren't giving them steroids, they probably wouldn't necessitate treatment for, osteoporosis or preventing fracture. But because you are exposing them to steroids, then starting a medication, would hopefully help to prevent the development of osteoporosis.
Correct.
The guidelines suggest that you could pretty much start bisphosphonates, denosumab, or anabolic agents like teriparatide.
Right. And we did give that opportunity for oral or IV bisphosphonate in all of the categories now, well, in moderate, high risk, and very high risk, unlike the 2017 guidelines, we had basically prescribed oral bisphosphonates first, then IV bisphosphonates if they were intolerant or didn't have a good response. And then we went down the numbers, went down the drugs, and really were very prescriptive. In this guideline, we realized that, if we're going to include BMD changes in not just fracture improvement, realizing that most of our studies are not powered or go long enough for fracture reduction numbers. We've now included the BMD's changes. Really, we want to give the provider and the patient the best opportunity to really find the right drug for them. There's a lot of reasons why patients won't want to take an oral bisphosphonate, and that might include esophagitis or severe heartburn, or they've read the news so much about atypical femur fractures and osteonecrosis of the jaw that they're just very afraid to start a bisphosphonate. And so we want those patients, those moderate, high risk, and very high risk patients, to have the opportunity through our guidelines to use a different drug.
Got it. So it sounds like, you're implementing shared decision making sort of you're baking it right into the guidelines to allow, patients and their providers to make the decision that works for them, because, not every patient with high risk for osteoporotic fractures may want or need the same type of medication.
Yeah, it still surprises me how many of my patients, and I'm in Oklahoma, but this was true even in San Francisco where I trained, do not want to be on anti-osteoporosis medication. They don't want to be on osteoporosis therapy because they've read too much, they've seen things on the internet, and it's really challenging to change some of these beliefs about, what the real risk of osteonecrosis of the jaw is, which may be 1 in a million, basically, 0.001%, with an oral bisphosphonate, versus they may have a 20% risk of a major fracture in 10 years. I mean, that's much more likely than the 0.001% of a osteonecrosis.
I totally agree with you. And I think this point about hesitation to start treatment for osteoporosis also is from the provider's perspective. I can't tell you how many patients I've had who've had vertebral compression fractures that were never treated with even oral bisphosphonates, right? Or people who've had DEXA scans and maybe they don't classify as having osteoporosis, but their FRAX score suggests, a high risk of osteoporotic fractures, and they're not started on treatment.
Right. And oftentimes they're offered, but they may say no. And so we actually did include that category in our guideline, because there is a fairly large number of patients that are moderate risk or even high risk on steroids that choose not to have therapy. And so, those patients really need to be monitored yearly if possible, biannually if the insurance won't cover it yearly, to make sure they're not dropping their bone mineral density too much.
Yeah, great point. And as we discussed at the beginning of this discussion, I mean, this can have sustaining an osteoporotic fracture with the risk is fairly high, has a huge risk of morbidity and even mortality, much more so than many of the very, very rare side effects that you hear about in the news.
We know that wrist fractures forearm fractures are osteoporotic, and most physicians don't know that when a patient sustains that's a multiple surgery fix. That's not a simple cast. That's usually a multiple surgery. And if it's their dominant hand, there's so many things they can't do. So even a wrist fracture that we don't think is that morbid actually leads to a lot of difficulties with ADLs.
Got it. Let's go to the other group. So we talked about the very high risk group that you suggest anabolic agents. We talked about the moderate risk group that you suggest basically something, anything to treat. What about the high risk category? And I see that this includes people with osteoporosis who've had BMD scores less than 2.5, who've had FRAX scores of, hip greater than 3% and major osteoporotic fracture of 20%. How should we think about treatment for these groups?
Right. So this is a patient that has osteoporosis but has not fractured. And so here we didn't so aggressively recommend an anabolic agent. We basically said you can start an anabolic agent, PTH or PTHRP or denosumab, over a bisphosphonate if your insurance company will allow you to do that. However, if that's not, if you can't do that, then we basically recommend oral bisphosphonates, IV bisphosphonates, raloxifene, and even romosozumab over no treatment. Strong recommendation for an oral bisphosphonate over no treatment.
Got it. So treat him with something and maybe perhaps anabolic agents
Correct.
first. Got it. And then, the last group would be the low risk group. Tell me about that group and how we should think about them.
Right. So the low risk group is basically they have no other osteoporotic risk factors other than steroids. And if their dose of steroids is less than 7.5, and the reason that dose was picked is because that's already accounted for in the FRAX. So if you check the box for glucocorticoids on the FRAX, that assumes the dose is less than 7.5 milligrams. So we said if the FRAX assessment, if they were over age 40, was in this low risk group of less than 10% for major osteoporotic fracture, less than 1% for hip, if they have a pretty good BMD T-score of greater than minus 1.5, that you basically could do watchful waiting and not treat, and then to follow up with a BMD every year if possible, every 2 years if not possible, and then to do the fracture risk assessment every year as you see them for follow-up.
Got it. So just to clarify, you mentioned, these are sort of otherwise healthy people without risk factors on glucocorticoids less than 7.5. But these same patients without any other risk for fractures on glucocorticoids greater than 7.5 would automatically fall in the moderate risk category. Is that right?
Yeah, that's right. That's a great point. And that's because the FRAX doesn't do a very good job of correcting for steroids more than 7.5. Canis et al. Actually did publish a number of years ago a glucocorticoid correction. And so, which we do mention in the paper, and it basically, you calculate the major osteoporotic fracture as you would normally, checking that glucocorticoid box. And if they're on more than 7.5 milligrams, you multiply the major osteoporotic fracture by 1.2, and that will give it a 20% increase. And then that may actually tip somebody from moderate risk to high risk. And so that's why it's important to do that. However, keep in mind, it still does not do a very good job for patients that are on very high doses of more than 30 milligrams a day. And that's why those patients are in the very high risk.
Currently, we're talking about sort of the FRAX and the bone mineral density. How do you account for things like, I don't know, inflammatory bowel disease, or you mentioned before liver disease, into these assessments where, they're not included in the FRAX? You're not going to get any help from a BMD. Are there patients that maybe they have chronic liver disease, but you do the calculations and they seem to be low risk? Would you still think about treating those patients?
Yeah, I would. I think we have to keep our clinical hat on and our judgment, and frailty, is also something to keep in mind. The current FRAX doesn't take into account falls or multiple falls. It doesn't take into account frailty, doesn't take into account type 1 diabetes. There's a variety of other things it doesn't take into account that we know increase the risk of fracture. So I think we do, in my opinion, I would err on the side of caution. And, the last thing you want your cirrhotic patient to do is get a hip fracture, or that frail young adult who has had really bad inflammatory bowel disease. And, now they're getting better because maybe they're on one of the integrin inhibitors or something, but they're still pretty frail. Yeah, you might think about trying to treat that patient more as a moderate risk patient.
Got it. And then, so let's say, you started my patient on an anabolic agent, my patient with PMR who was at, high risk or very high risk of fracture. How should we monitor these patients over time? Like, when should we decide to stop a medication or to reassess their risk of fracture? as the year goes on.
Right. So basically for all categories, low, moderate, high risk, and very high risk, we do recommend repeated DEXA scanning, except for children. And that's only if they've had new back pain or new clinically significant fractures. But for everybody else, even the low risk, we do recommend that you repeat the BMD, the DEXA, every 1 to 2 years, as long as they're on steroids. And so if they're able to come off of the steroids, then you should do a final assessment. As they're stopping the steroids, you can look and see, well, what's their BMD now? Did it come up? Were they on an anabolic agent, or were they on denosumab, or even a bisphosphonate? Are they now not in a high risk or very high risk fracture state? And can you basically watch them just every 1 to 2 years after that with a BMD? So we do recommend following them while they're on steroids, and at the end of their steroids. The BMD at the end of their steroids can help you decide, do you need to do sequential therapy, or can you stop therapy or continue the current therapy they're on?
Got it. So, somebody that has osteoporosis, they're started on treatment, has osteoporosis and is started on glucocorticoids. After finishing their glucocorticoid use, if they still have osteoporosis, they would benefit from treatment as you would for other people.
Correct.
But there's some tricky things about, if a patient is on an anabolic agent and no longer is on steroids and does not have osteoporosis. Why do we need to think about that group somewhat differently?
So this is a great question, and I think it's really critical for our providers to understand now that drugs that build up bone quickly, when they're taken away, have the potential, not always, but have the potential for very rapid bone loss. We knew that medicines like denosumab, which can be taken safely for at least 10 years and probably longer, and you continue to build bone. We knew before COVID that when you stop denosumab, if you've been on it for more than 2 doses, you do have an increased risk of losing bone, especially in your spine, and getting vertebral fractures. But when COVID pandemic hit, and patients couldn't get into their doctor's offices to get their repeated denosumab injections, we saw a tremendous increase in patients developing rapid vertebral fractures, sometimes multiple vertebral fractures, in as early as 7 to 9 months after the last dose of denosumab. So it's now strongly recommended that when denosumab is stopped, that you start an oral or IV bisphosphonate at that 6-month mark, if possible. It's not clear from the couple of papers that have been published which formulation of bisphosphonate works. One paper suggested oral bisphosphonates for a year were effective at preventing the fractures. The paper that looked at IV bisphosphonates found that they needed 2 doses of IV bisphosphonate every 6 months. And so it's not really clear which is the best way to go. I think you could do either, but you may need a higher dose or more frequent dosing of IV bisphosphonate than what we usually use for osteoporosis.
And does that also come into play for the PTH or PTH analogs?
Yes, it does. So the teriparatide and abaloparatide, they build bone very effectively. And usually you use those drugs for 1 to 2 years. When you stop those drugs, you have a slow decrease in bone mineral density and a slower return to fracture risk. But it is now recommended that you follow those drugs with either an oral or IV bisphosphonate, or you could do PTH or PTHRP followed by denosumab, and then do the bisphosphonate after that.
Is the length known for how long you should continue bisphosphonates after teriparatide or abaloparatide?
It is not completely known, but it's recommended a year.
A year. Okay. So all right. So I guess that's sort of the downside of these anabolic agents. They sound great. Like, would you want to either build bone or maintain bone? I think most patients will say, oh, I want to build bone. But I guess the downside is that, well, you build bone, but, that requires some additional treatments, going forward in order to preserve that bone density that you have gained. So it's, I guess they're a little bit trickier in that sense, that you have to think about not only starting this medication, but having the expectation that once you finish this drug, you'll likely, have to switch to a different agent, at least for, a short period of time to maintain those benefits.
Yes, you're completely right, John. And so for patients that are resistant to a bisphosphonate up front, you need to make sure when you're talking to them about the anabolic agents, denosumab and romosozumab, the anti-sclerostin agent, that you let them know they will have to finish a course of these drugs with a bisphosphonate for at least a year. And probably not more than that, except possibly denosumab if you choose the IV bisphosphonate route. But then, and they have to be willing to do that additional year of a bisphosphonate. Again, the risk of osteonecrosis of the jaw or atypical femur fracture with a year of a bisphosphonate is exceedingly low. Most patients that get those have been on bisphosphonates for more than 5 years. The IV formulation has a higher risk than the oral formulation. But we do have to recognize that our patients tend to have a higher risk of osteonecrosis of the jaw because our patients tend to have a higher risk of osteonecrosis of the jaw because they're on steroids. They're also on immunosuppression, and they may have diabetes and other comorbidities that increase the risk of osteonecrosis of the jaw.
Got it. So in addition to medications, what other types of interventions do these guidelines recommend for people that either, have osteoporosis or maybe at risk because of their glucocorticoid use?
Yeah, this is a great question. Patients really want to take their health care into their own hands and do what they can, either with medications or to avoid medications. So we really recommend that patients take a careful look at their dietary intake of calcium. We know that dietary intake of calcium is much better for maintaining and building bones than oral calcium supplements. So we recommend as much calcium in their diet and only to supplement with an oral calcium up to 1,200 milligrams a day. We recommend that physicians check their vitamin D, 25 hydroxy vitamin D level, and help them maintain a vitamin D level between 30 and 60 or 30 and 90, depending on what your institution's readouts are, with supplementation if needed. We recommend weight-bearing exercises or even muscle strengthening exercises. We know that if the muscles work better, the bones are stronger underneath them. And then avoiding smoking, limiting alcohol are all great interventions patients can do.
Fantastic. And, having developed these guidelines, I imagine there were some areas of unknown or uncertainty. Can you talk a little bit about, some of those gaps and the information that you didn't know when you created these guidelines?
Yeah, I think, funny enough, the majority of these guidelines are built on data that is limited. So we have great data for all of these drugs in postmenopausal osteoporosis and for some of the drugs in men with osteoporosis. We have limited data for these drugs in glucocorticoid-induced osteoporosis, and when we have it, we have really leaned heavy on those studies. But because we have such limited data on fracture and even to a certain extent BMD gains, most of the guidelines in this study are low quality evidence to very low quality evidence, which feels really bad when you're making a guideline. You really want it to be the strongest data possible, but this field just does not have the head-to-head comparisons, the randomized controlled trials that vasculitis has, that lupus has, that RA has. And so we're really limited in terms of really how certain we can be on this data. I would anticipate that as this living model goes forward, that we will see additional changes to these guidelines, perhaps moving anabolic agents up to be the number one start before bisphosphonates for both high risk and very high risk patients. And part of that is because we're now starting to see studies done. There was a really great study called the Data Switch Study, where they looked at patients that were started on, for instance, teriparatide and then switched to denosumab, or they were started on denosumab and switched to teriparatide, combinations of drugs. And we can see now that an anabolic agent after a bisphosphonate doesn't build as much bone as if that patient hadn't been on a bisphosphonate to begin with. So I think if we start to have more data that really shows that a short use of some of these other agents can really pack a big punch in terms of building bone, maybe we won't have to have patients on osteoporosis medications for as long as we do for bisphosphonates and denosumab and some of the other drugs.
Oh, fantastic. We interviewed here several lead authors of various different guidelines, and they always, say that it was a struggle. And at the end, they're very excited about the work that has been done among many, many people. But what impact would you hope that these guidelines have on people with rheumatic diseases?
The number one impact is I hope we can get more patients screened and treated. We still, I think, when I look at training programs around the country, when I look at our own training program and our own faculty, we still have limitations to us getting everybody screened and getting everybody on treatment. I think I would really like to see the ACR use these guidelines and make some perhaps flip cards that we can have in our offices that we can show patients, this is your risk of fracture. Here's the 10 people that are going to fracture in 10 years, or 100 people in 1,000 that are going to fracture in 10 years if you're not on treatment. And this is the number it would be if you were on treatment. I think whatever we can do to empower our physicians and our patients, because sometimes they actually look at these guidelines, to help them make good decisions about wanting to have therapy and then getting the right therapy is really critical. The last guidelines, we were really focused a lot on avoiding harm. I think we have now, 6 years later, a lot more evidence of the good that comes from these drugs. And we are getting more and more drugs that have less harm. And so I think we should be more aggressive at treating our patients.
Fantastic. Mary Beth, thanks for these insights into the most recent GIOP guidelines. I really appreciate all the hard work you've done over the years to make this happen. And, I think you led this fantastic paper, and hopefully it'll translate to, more patients being treated, less patients having fractures and having, many of those complications that we discussed.
Oh, yeah. If we can avoid those fractures, that'd be great. A big shout out to Linda Russell, who was co-first author on this manuscript. She was co-chair with me on the guideline committee, and we had a great core team and then excellent literature review team and evidence building team. So really, it's a labor of love to do these guidelines. And, we're actually in the process already. I think that this paper is maybe not even on PubMed yet, but we're already in the process of starting the revision. So if anybody wants to volunteer to be on the GIOP guideline committee, please reach out to the ACR and let them know. We need more pediatric people. We want a group of clinicians that are in private practice even. We don't want just academicians on this guideline. It needs to be real world clinicians weighing in also. So thank you, John, for inviting me today. It's really been a pleasure. And my email is available through the ACR. If anybody has specific questions or concerns, please reach out to me or Linda Russell. We'll be happy to answer those.
Fantastic. So we'll have, information about where to find the guidelines on our website at acronair.org. And certainly, once you have the new version, we'd love to have you back and discuss. Thanks so much.
Thanks. That's great. Bye-bye.
Well, there you have it.
The 2022 ACR guidelines for the prevention and treatment of glucocorticoid-induced osteoporosis. They're a little complex, but fortunately, there are charts and figures included in the guidelines that can make it easier to risk stratify your patient and help to select the appropriate pharmacologic treatment. You can find links to these guidelines at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app.
Thank you all for listening, downloading, subscribing to our podcast, and rating us with 5 stars, or however many stars you think we deserve.
Keep ordering those DEXA scans.
And of course,
stay healthy.